Very good afternoon, and thanks, Krishnendu, and thanks for AIOC. Congratulations to AIOC for organizing this first ever virtual conference. I'll be speaking about IOFB, macular IOFB. So if IOFB, intraocular foreign body, is located near the macula, there's a high possibility of macular damage, and also the damage is more so during removal. We'll have to be very careful during removal because there might be enlargement of the penetration site, there might be excessive fibrosis after surgery and retinal trauma. So as we all know, the predictors for worse outcome in IOFB are poor initial visual acuity, location of IOFB in the posterior pole, associated lens injury, retinal detachment, and endophthalmitis. So when to intervene? Ideally, an IOFB should be intervened at the time of repair of the entry site, but because inflammation caused by the IOFBs may lead to rapid surrounding of fibrous capsule all around the foreign body, and which may make delayed surgical removal more difficult. So the timing of intervention is primarily determined by the risk of endophthalmitis. Now, if the risk of endophthalmitis is high, an immediate vitrectomy with the foreign body removal is indicated. The wound should be closed as early as possible. But there are some advantages of delayed surgery too. It's delayed as in 7 to 10 days because initially when the globe is ruptured, a 23 or a 25G trocar might be difficult to enter the eye. A sealed or repaired globe would allow for better insertion. There would be a decreased risk of uncontrollable vitreous hemorrhage, and there's a high risk of separation, high rate of separation of the posterior vitreous, thereby removal of the vitreous more easy. So what are the surgical goals? To clear the ocular media through removal of the cataractous lens, to remove the vitreous scaffold, to remove the posterior haloid, to identify the retinal breaks. Now, vitrectomy and removal of the intraocular foreign body is done by magnets or forceps. Best tool is to extract when it's a magnetic foreign body by strong intraocular magnet, as we'll show in my videos, which will follow later on. The IOF will align itself to the long axis, thereby making it easy to extract through a small sclerotomy. Dislodging an impacted foreign body can be tricky. In my second video, we'll be showing how we are dislodging an impacted foreign body. So these are the foreign body forceps. This, as we Indians are quite aware and quite proud of, Dr. Manish Bapai's claw forceps. There are other forceps also, and these are the pictures of an intraocular magnet. Now, following the IOFB removal, a thorough peripheral vitrectomy has to be done. And in case of an associated RD, the RD has to be managed. So if there's concomitant cataract, preferably an primary IOL insertion should be done. It should be left aphakic if we are planning to remove the IOFB through a limbal incision. So I'll straightway go to my first case. He had a trauma while working on the grinding machine, and the X-ray showed a metallic foreign body. As we can see, there's cataract, so thorough lensectomy is done. Vitrectomy is done, clearing the vitreous hemorrhage. Now we can see a blob of clotted blood, which will actually guide us to the region where the foreign body is impacted. So once the clotted blood is removed, now we can see the foreign body. It is the moment we went for a removal for dislodgement, there was hemorrhage. So the hemorrhage has been taken care of by diathermy. we would need an intraocular magnet. So the sclerotomy is increased to a 20G. And by handshake technique, the foreign body is removed. Well, the amount of time that we have, can we have another video?
Sorry to interrupt, respected Dr. Soumen. Can you please sum it up within 30 seconds, please?
Yeah, we have 20 minutes more. So can I have a 5-minute video?
So 5 minutes would be really very more, because we also have a next speaker, and we also have to go for the panel discussion as well.
Yeah, fine. So I will just wrap it up, I think, because since we are there's a lack of time, I'm sorry, we can't show the second video. So to conclude, the new tools in the management of macular IOFB now that we have, which have facilitated our surgeries, are one that we can now use a high brightness xenon light source, which is helpful in IOFB visualization. We can also use chandelier light source, use of wide angle binocular indirect ophthalmoscope, which is with a non-contact viewing system. It improves the ability to visualize posterior segment structures.